Assalamu alaikum. I hope you enjoy the lunch. It was a great lunch. Thank you, Dr. Hind. And I will be a pleasure for me to lead and share the last session of such a great meeting. And also it's a pleasure to me to introduce my friend and talented young consultant hematologist, associate professor at King Abdulaziz University. She has several publications in a blood bank and a member of AABB Global Transfusion Forum and member of ISBT Committee Standing Committee. Pleasure, Dr. Maha, please. She will be talking about how to improve incident reporting.
Thank you very much, Dr. Furja. Happy to be here today and very grateful for Dr. Hind and the rest of the Ministry of Health team and DAMI team as well for inviting me and organizing this beautiful event. Okay. I'm talking today about improving incident reporting. I work primarily as an associate professor of hematology and transfusion medicine at King Abdulaziz University in Jeddah. I am also the director of the blood bank at the University Hospital. Recently, I was elected the regional director of the Eastern Mediterranean region for the International Society of Blood Transfusion, and I also work as a subject matter expert with the Ministry of Health. As everybody mentioned since the day started, we know that any hemovigilance system relies heavily on reporting and accurate reporting, to be specific. So we need to hear about donor reactions, transfusion transmissible infections, errors, and near misses. Once these are recognized by the healthcare professionals, then they need to be reported, and that's where we collect them as transfusion medicine experts and analyze them and come up with corrective actions. So where is the problem? There is a number of publications that I'm going to share that show that people do not report most of the adverse events, transfusion reactions, or donor reactions. So for example, this is a paper that was published in 2015 specifically about TACO events with platelet transfusions. In this paper, they looked at retrospective data of 13 years of passive reporting, just completely relying on the reporting system that was in place in the hospital, and compared that with 30 days of active surveillance. So everybody who received a platelet transfusion were then examined and seen to see if they developed features of volume overload or TACO. And over 13 years, the percentage of reporting event was 1 in almost 6,000 transfused platelet units, while in 30 days of surveillance only, it was 1 in 167 transfusions. So you can see the huge magnitude of missed reported reactions. In another publication, also from the United States, 4 sites participated. They looked at 200 randomly selected transfusion events from each center of these 4 centers each month for a total period of 6 months. And they reviewed these data and looked at the reactions that were picked up from the patient files, looking at vital signs and doctor's notes. So they discovered 4 possible TRALI events. All were suspected by the physician. However, only 1 was reported in the reporting system. They discovered 39 TACO events. Doctors were not always only suspected those in about a half of them, just more than a half of these cases, but only 2 of the 39 cases were reported in the system. They also picked up 39 febrile non-hemolytic transfusion reaction events. About 30% of these were reported, and 14 allergic reactions. About half of these were reported. And finally, I share a paper we published from our center in Jeddah University Hospital, looking at the same thing. We tried to do active surveillance. My research team went to the ward, looked at every patient who received a transfusion within the first 24 hours after the transfusion. We looked at vital signs and physical examination to see if there were any events that we're not hearing about. And then we compared the transfusion reactions that were picked up in that period and compared it with historical data from the year before in the exact same month. So August, September, October of 2018 compared with August, September, October of 2017 and 2019. And we did prove that there was a statistically significant difference in the rates of reactions that we picked up using active surveillance when compared with historic data and data from the following year after we stopped active surveillance. Unfortunately, those unreported events are missed opportunities for improvement and prevention of recurrence. So if we look back at this, those are the things we want to hear about. Physicians need to recognize them and then need to report them. As Dr. Fatin mentioned, and Dr. Aisha also mentioned, the need of education of physicians and nurses about the possibility that what you're facing, that adverse thing, the changes in the vital signs, the changes in the patient status actually represent a transfusion reaction. So that knowledge has to be there. However, the system also has to be helpful. We have to provide healthcare professionals with very clear definitions of what needs to be reported, definitions of reactions, donor reactions, what is a near miss, etc., and how to report. So that has to be clear. That knowledge has to be provided. And the reporting has to be user-friendly. And I'm going to elaborate a little bit about this user-friendly mechanism. So the usability of the reporting system basically means the system is appropriate to the purpose, and it has a specific definition in the ISO standards. So it must cover effectiveness, the ability of the system to capture, the ability of the user to complete the task that they were supposed to put, and the output out of this has to be of high quality. So not just finishing the task with no enough details. The system has to be efficient, and the level of resources required for the user to perform the task in terms of time and technical expertise must not be high. And finally, which is always missed, satisfaction. Are users happy about using the system? And I have to say, most hospital information system, I'm not going to talk about incident reporting system, but most hospital information system, unfortunately, they ignore this completely. Nobody ever asks us whether we're happy with our information systems, but we have to make sure that our users are actually satisfied. And there is a set of guidelines that were published by the US government about usability guidelines, so these can be utilized. Another thing that we really need to make sure we have is monitoring and recognizing the user experience. Our users, the perceptions of them, the responses resulting from the use of the product system, the reporting system, is it satisfactory? So the user experience has to be really, the user experience testing or usability testing has to be performed before any system goes live. And this is something we have to remind ourselves of once we, inshallah, have our software ready for wide utilization. I am going to share a couple of publications, just the titles of publications about describing the user experience testing for incident reporting, not in the medical field, but in other fields. But people do actually have standardized methods of testing usability. So for example, this is a system usability scale. It's made of 10 questions about whether the user thinks the system is complex or not, whether they would like to use it frequently or not, whether it was easy to use, did it need a lot of technical expertise, etc. So these things can be easily utilized. It's very simple to use. So if we identified the things we want reported, if physicians and nurses had the knowledge about them and how to report them, and they recognize them, now they have to report them. Are they willing to report them? So many people, many of the speakers before me already mentioned that many people were actually not keen on reporting events because of fear of punishment or blame. So I'm gonna mention more about that. So in one very interesting paper published in 2021, The author started by summarizing from the literature what are the features that were contributing to underreporting. So he recognized that there were organizational factors such as the culture, a blame culture, management behavior, complex or poor reporting system, process or design, which we already mentioned, and lack of feedback. So people put in the reports and nobody came back to them telling them what the conclusion was. Personal fear of adverse consequences. Some people did not understand the value of reporting and thought it was pointless. Lack of sufficient knowledge about what needs to be reported, personal characteristics. Also, it was identified that the error type, mild versus severe, the severity of the error and the incident, and the frequency of it happening also affected whether people wanted to report incidents or not. So in this same paper, it started with the qualitative part, and they identified this framework that affected the willingness of healthcare professionals to report adverse events. So they identified 3 factors: organizational trust, perceived benefit, and perceived risk. All of these eventually interact and result in whether the user would like to report or not to report a specific incident. So the organizational trust basically meant whether I can trust my organization or my healthcare system to have my back when I am in a vulnerable situation. If I admit to a mistake, am I gonna be put at blame or punished because of this, or do I trust my organization enough that this will not be taken against me if I share this piece of information? Perceived benefits included benefits to self, for example, feeling better about oneself, maybe being awarded for reporting things, and benefits to organization, because the organization will, if I trust that the organization is going to use the data I put in to improve healthcare, and also, of course, benefit to patients. So these are balanced in the mind of the healthcare professional before they make the decision to report or not. And this is balanced with the risk that might be faced by using a lot of time, lots of resources, and of course, fear of blame or punishment. So I'm going to elaborate a bit about organizational trust, and another term that's commonly used, which Dr. Muna used as well, is psychological safety. They are very close to each other, and I'm going to use them as if they are the same. So organizational trust starts with the thoughts of the healthcare professional. So if the healthcare professional believes that the motivation beyond the reporting system is good, it's not there in order to collect people's mistakes. No, it's there to improve the care we provide to our patients. The reporting system protects anonymity and confidentiality. Reported data will be analyzed by competent professionals. That was a very important point for many healthcare professionals. They need to trust that the data they put in is analyzed by individuals who understand them and not individuals out of the field. And that we need to trust that the patient care will improve by reported data, and that the system is not only there just to complete paperwork and to say we have a system, but actually the data will be used to improve patient care. And a just culture has also to be emphasized because the risk that individuals perceive is actually extremely high in all the publications about the willing to report. So a just culture, basically a good definition of it is a system of shared accountability in which organizations are accountable for the system they have designed and for responding to the behaviors of their employees in a fair and a just manner. In the same time, employees have to be accountable for the quality of their choices and for reporting errors and system vulnerabilities. In a just culture, we don't punish people if they report a mistake or if they are identified to be involved in a mistake. Basically, reckless behavior is punished, obviously, and intended harm is punished. However, individuals who have errors because of simple lapses in memory, poor training, etc. Those are given counseling and coaching. We have to remove incentives of shortcuts, etc. And I'm going to share with you a model that it's called, it's published by Reason et al. And it was also published by the NHS as a just culture guide. So basically, when you are faced as a manager by an error, how do you manage the individuals that were involved in this error? So the first question to ask ourselves is, was there any intention to cause harm? Did this healthcare professional mean to harm this patient? If the answer is yes, then definitely you have to end there. It's going to be a legal issue. You might have to talk to the police, etc. However, if the intention was not to harm the patient, then we ask ourselves whether there was a reason why this person did this because of substance abuse or illness, mental illness or physical illness. In these cases, if we identify that there were those sorts of issues, then these have to be managed accordingly. However, let's imagine a situation when the healthcare professional did not intend to cause harm, did not have mental or physical illness resulting in this problem. So then a few other questions, very helpful questions. Are there any policies or protocols in place? Or, well, sometimes a problem happens because there is no policy in place or no protocol. And were the protocols or the policies workable, or did they come from upper management, not applicable to the work situation? And did the individual know the policies and knowingly departed from them? In these situations, you might need to develop those policies, make sure they are workable, and make sure people are aware of them. And if they are aware of them but not practicing them, then they need coaching and counseling and training. Other questions, substitution questions. So if you brought somebody else in this situation from a peer group, so let's say a medical technologist performed an error, we have to ask ourselves if another medical technologist with similar training and education was there in this situation, could they have done the same mistake? And did the person receive the training? And did the person who is in charge of supervising this person, did they give the specific monitoring or supervision they were supposed to give? So all of these, if you answer yes to these questions, depending on the question, you might identify system issues that you have to work on. A problem in the IT system, a problem in the manual forms that make people at risk of making errors at that specific area, regardless of who the care professional is. And for our systems as well, we have to ask ourselves, did we have any mitigating do we have any mitigating circumstances? If an error happens, do we have things in place to catch them before the harm reaches the patient? In another publication also, they also did a qualitative study for physicians only. This was very specific to physicians, MDs, and they looked at why they won't be willing to report incidents. So the main thing, before I go there, the main thing, of course, as we already talked, was this fear of blame. Was it just fear of blame? Did they only just fear that they would be punished if they reported errors, if they were involved in it? And it was there. The fear of blame was there. Fear of reporting included fear of litigation. It included fear of impression of incompetence in the eyes of oneself. If I said I made a terrible mistake, I would feel bad about myself. My friends and colleagues might hear about this and also blame me, or I might look incompetent in their eyes, in the eyes of my superiors, and also people are really scared about the eyes of the public. And I think that's an issue that we see also in our area of the world. But other things also, in addition to the fear of blame, out of this study, other issues, really other points were recognized as well. So for example, some physicians, and many physicians actually, thought error was, you cannot really be error-free, you cannot work error-free, so errors are always going to happen, so what's the point of reporting them? So they did not understand the value of reporting these errors in order to make system improvements. They seem to accept and tolerate errors as part of medical practice, and they said to err is human, and you can never make us error-free. And that's where they did not see the value of reporting. And talking as a clinician, I'm also a clinician before I became a transfusion medicine physician, and only in transfusion medicine is where I learned the value of reporting errors and in order to change systems. So I don't think many clinicians actually get exposed to that part of knowledge. So for example, we have some statements that were said in the study. So somebody said, what good does it do? It's not like it could ever make us error-free. Okay? And somebody else said, the best intentioned doctor will still make mistakes. I don't see a point of reporting them all. Interestingly, other points also arise in this paper. Some physicians wanted to reject bureaucracy. They don't want anybody to tell them what to do. Somebody commented that doctors are the worst people to follow mandatory rules. If there is anything mandatory, doctors will think of a way of not doing it. And again, it comes back to the misunderstanding or lack of understanding of the value of what we are doing here. So if we go back to this prerequisites of the system, as I mentioned, we must have clarity of definitions, clarity of what needs to be reported, clarity of the reporting process. We must have a user-friendly mechanism. But in the same time, we need to add these. We need to add transparency. Users need to know who is evaluating their incidents. We have to give them the trust and the assurance that whatever you're reporting is coming to trustworthy individuals with adequate qualifications. We have to build trust, and the trust has to be built in all levels. So for example, as director of a blood bank, I have to be welcoming of reported errors. People should not be afraid to approach me with problems or errors or mistakes. We have to sit together to work out a solution and a corrective action. And that's on a blood bank level, but how about on a national level as well? We really have to work on this. I think this is whenever, like if we talk among ourselves right now, fear of blame is still the biggest obstacle we're facing while we're asking people to report incidents. In the same time, we really definitely need to communicate value. Why are we doing this? Educate people about the need and the benefit of reporting incidents and reactions. We need to share feedback with those who put the reactions in. Whoever puts an incident in needs to hear from us. Yes, we received your input. That's what happened. So this is what we think it is. We think it's a mild or a moderate reaction, and etc. So depending on the situation. In the same time, people need to hear about improvements. And I think that's a success in the SHOT system. So the SHOT system publishes this annual report where they share lots of the reactions of the statistics, but in the same time, they suggest and share improvements to the system to prevent additional errors and reactions from happening. So that sharing is also very essential, and we really need to work on it while we move forward with the hemovigilance system. A few of you asked already about the role of artificial intelligence in reporting, and I think it's coming. I don't think it will replace the human factor. I think we as clinicians, as nurses, as blood banks, we still need to work hardly on what you already mentioned. AI is coming, as you can see from these publications, monitoring vital signs for a patient being transfused or after transfusion helped pick up more reactions than those reported by the clinicians or the nurses. Still, even with AI in place, we still need to work on the elements we already mentioned. And that's all I have. Thank you.
Thank you, Dr. Maha. Our second speaker, Dr. Abdullah Mashi, his topic is about role of changing the management in successful hemovigilance implementation. Dr. Mashi.
Assalamu alaikum wa rahmatullah. Good afternoon. First of all, I'd like to thank the organizing committee, Dr. Hind and her team, and also Jamiat Demi for their kind invitation to be with you today and to talk about this topic, which will be, at least from my side, is something that we really need to pay attention to it when we are trying to implement not only hemovigilance but any other type of initiatives that would involve transformation from one status to another. I think I'll have a problem with reading this very small, so I lose my magic eyes. Okay, so what I'm going to present in the next few minutes is just to have a summary of the current situation of hemovigilance in Saudi Arabia, and then to just remind ourselves with the elements of hemovigilance system. I'll introduce the importance of change management and how it could be considered when we are trying to implement any new system or any new initiative. And I will end up with just touching on one of the change management models that very popular, which is called ProSci, and I will explain two of the tools that used by this strategy to help making the change successful. So as we have seen so far since morning, there are a lot of actually talking about hemovigilance and the elements of hemovigilance, and we can appreciate that it's very complex chain of processes, involves many stakeholders, involves many people, technologies, patients, donor. So it's very complex situation we find ourselves to monitor and to get 100% reporting and tracking of everything happens to the donor or to the patient in this cycle of from the vein of the donor to the vein of the patient. However, there are principle of hemovigilance. It actually include all these elements, starting from having a policy, having procedures, having a system to report, having all elements that you need to have to end up with clear reporting and meaningful reporting that will help to prevent the outcome and to minimize the risk to both patient and donors. But when it's come to implementing a hemovigilance program, it's quite a challenge. It's really a big challenge. It's not something easy. So when we find ourselves in this situation, and I think Dr. Mona showed in her presentation that for UK it took more than 25 years to find or to reach to the situation that they 100% of hospital reporting incidents. So what about our situation? We still have actually a lot of challenges, as Dr. Mona have shown, as Dr. Fatin and Dr. Maha also explained, that there are a lot of shortcomings and challenges happening in our situation. But what we are now, in my opinion at least, how I see the hemovigilance in our country, I see it like this. We're actually now trying to jump from one side and to go to the other side. So now we don't have hemovigilance, or we have what is called reporting system. It's more statistical maybe tools rather than actually a complete hemovigilance system. So now we are jumping, we are on the air. Hopefully we can land with all the leadership support and all understanding of how much change we need to consider and how to reach to that. So the end point, hopefully we can have and land in the right place on the right side with a national hemovigilance program. So for any project actually, including implementation of successful hemovigilance system or program, we have to have three things. We know we have the current situation and we have the future state. And between these two states, we'll have a transition states. These transition states had a lot of things. We have to have a project planning, we have to have knowledge, we have to build our policies, procedures, reporting system, education, training, etc. So we have two sides of this journey, I would say. We have the technical side, which is usually covered by project management. And we are very good in this. If we have anything we want to do, we'll say, okay, we'll make it as a project management. So we'll define all aspects of project management. But also we have the people side of things. We are not just talking about artificial intelligence so far, at least for me. We still reality, we have people there. We have physicians, we have donors, we have patients, we have nurses, we have lab technicians. So a lot of people involved in the process of hemovigilance. So we have always to consider them. So from the technical side, it's easy to solve all issue by just simply having a good project management, getting the right people in the project, designing the project well, having all the objectives clear, and then have a measurement for the project progressing. But on the people side, what we need actually to have is a change management. We have to change people to adopt this system. So it's about actually not only having a project, design and develop and deliver, but also we need to engage people. We need to adopt their behavior. They have to adopt the new technology, the new system that you are building. They have also to use it. It's meaningless if you have a very nice form or system for reporting, while there is only like 70% of hospital using. And this is what we have now, as Dr. Muna showed, that we're still lacking a national reporting. Although we have a Yaqada system, but still not all hospital and not all regions using that one. So we have an issue with people. And to solve this issue, we have to consider the principle and strategies of change management. So what is a change management? It's actually basically, in a simple definition, it's actually to control the process of change. How to take hands or people with their hands from one state, the current state, to the future state. But scientifically, it could be defined on two levels. In the project level, it's actually an application of structured process and sets of tools for leading the people side of change to achieve desired outcome. On the organizational level, let's say on the Ministry of Health as an organization, we talk about leadership competency, to lead and to enable the change within their organization. There is nothing will happen if the leadership is not involved, if the leadership is not aware of the need of the change. We are just talking about something that would never exist. So leadership is, as organizational level, it's the one who usually drive and support any change on the culture or in the organization. It's also a strategic capacity or capability designed to increase change capacity and responsiveness to the change. Why change management is important? As I said, we have, this is when we apply a change management strategies, we will move from current situation to the future situation with very clean and nice and tidy transition, state. But these three things under the change management will ensure the success of the change or reaching where we want to go. However, if we miss or we underestimate the people side of change, we'll end up with a situation like that. We'll have a difficulty in transition states, ending with a future state which is not complete. There are a lot of problems with the future situation, and we will not achieve the success we want. This is maybe very, we don't need to read in details, but simply it's to show you what is the impact on the project, both from the side of cost and the risk, if we don't consider effective change management. So, for example, to the project that do not have or manage the people side of the chain, usually the project will be delayed. You may miss the milestone that you have already put. The budget maybe will run out while you haven't achieved your target. There are also a lot of risk for the project. There is a resistance, and I'll talk about this in a minute. A project could be put on hold by leaders. They are not seeing this project achievable, so they will just say, no, forget about it. We have to do something else. And also there are a lot of risk that to the organization itself. It could also lead to loss of investment in this project if it took like a long time not seeing any visible outcome. So what is the greatest contribution to change management successful? If you want to change manage anything and we want to make sure that it will be a successful change, we have to consider some enablers, if I would say. The first and most important one is the active and visible executive sponsorship or leadership. As I said, without leadership, nothing will happen. So leadership is a key in any change management. whether it is the Minister of Health, whether it's a deputy, whether it's a hospital director, whether it's whoever involved in hemovigilance, we need to make sure that they actually active and visibly involved in this transformation. Also, we have to have a structured change management approach. We have to have frequent and open communication. This is, again, another key issue or enabler or contributor to success. Employee engagement and participation in the change. And I don't know who has mentioned this. Sometime, and Dr. Maha, I think, said that we find that people actually, they are not happy with the system that they should use. So as an expert, we may design a perfect system for reporting, but when we give it to the user, they don't like it. Simply, it's not what they are thinking to have. So we have to always think about this at some stage, and I will come to this. Also, dedicated change management resources. It's actually, unfortunately, this is not being considered in many project management now. We just think about the technical side. We don't pay much to getting somebody who's trained in change management to help us to transform people, not only the technology and the system and the paperwork. No, we need the people themselves to be adapted to the new change. So their contribution is very important. And also integration and engagement of the project management. Change management and project management should work together. It's not two separate identities. They should be together, focusing on the same objective, moving towards the same target or outcome. On the opposite, what is the greatest change management obstacle? Well, as I said, the involvement of leadership is the key enabler or contributor. If you lack the executive support and active sponsorship or leadership involvement, you are lost. If your leader is not always supporting and understanding what you are trying to do, and everybody speaks the same language, you will find a lot of obstacle in the way. So it's very important to make sure this is happening. Lack of effective communication usually leads to misunderstanding and misleading information that spread all over the environment. Lack of change buy-in by the people who are affected by this change. And also it can resist also or create resistance as we go. Limited knowledge and resources for change management. If you don't have people who are really well trained in change management and they get them involved as early as possible in your project management, you are risking your project at all. And also, if you allow this to happen, if you don't effectively manage the change that you're inducing, you will end up with a resistant culture and resistant attitude, because people do not want to change. This is a nature thing that I don't want to change. If I'm happy now, I don't want to go home tonight, for example. I'm happy with sitting with you and talking. I can keep talking unless maybe doctor asks me to stop. So this is a situation we find ourselves there. We need to make sure that we are really not resisting the change. We understand this. I'll explain it in the next slide. So there are different methodologies and models when it's come to the change management. So I just want to share you this model, which is a pro-site change management methodology. It is one of the most popular and common methodologies, and I like it for two reasons. The first one, this is the one I know, because I'm trained and I'm certified change practitioner on this methodology. And the second thing, I find that you can use it not only in the professional level, as to implement like hemovigilance, but also you can use it on the very, very simple personal level. And as you will see, inshallah, in a minute. This model, without going in details, it has three main arms or points. The first one is the triangle there, which is called BCT triangle, and also the ADKAR, which is in the middle, ADKAR model, and then the three stages of change management. So when you put these things together, you ensure that your transition or your moving from the current status to the future status will be successful. So I'll just give some more details about the first part of this model, which is the PCT model. it's very important to understand what is the critical aspect of a change to happen or to be successful. This model summarized 4 main aspects or critical aspect for success. The first one is on the top, which is the leadership or sponsorship. These are the people who you get the governance, you get regulations, you get the agreement for the change themselves. So they should be there and aware of the change and supporting the change. You have also the project management, which is on the left, on the blue side, on the left side. It's about the technical side. It's about actually how to design the project, how to deliver the outcome within the time and resources available for you. And we have also the change management, which is basically considering the people side of this change. And this, in the middle of this shape, you see the success, where we want to go. What is actually the definition of success? If we want to say that we want to implement a national hemovigilance program, so we have to define this, what this system look like, how we need to reach that step. So by defining the success, all these 3 triangles or angles will be as equal importance. The time you lose one of them, you lose all the project, or you lose all the success. So you have to keep track of all these 3 main critical aspects of the change. The good thing with this model that you can actually turn this whatever I have explained now to a number. So you can have analysis and an assessment for the project, and you can scale it according to the risk that each part of this triangle will be affected. And usually in the beginning of or early in any project, you will have a lot of red colors, a lot of risk coming on. So you have to go back and plan an intervention to reduce this risk, and to make it either to the orange or to reach by the end of the project. Hopefully you have all these, the leadership, project management and change management on the green zones, so we'll end up with a successful implementation of the change. This is just a scan shot from how we can assess this and how we can get numbers to this square or to that shape is basically by answering some questions and scoring them from 1 to 3, and then you have a number where you can say whether we are in the high risk level or where we are okay, or we are in the middle, we need to have some work. Another also method or model in the ProSci is the ADKAR model. And this ADKAR model is basically talking about the 5 elements of successful change. If you are able to reach this level of or outcome, that means you are successfully changed. It starts from the A, which is the awareness, desire, knowledge, ability, and reinforcement. So in each of these stage or outcome, it's good to make sure that you cannot actually move from one side to the another if you are not fully understand or fully achieved the first side of or first step of this model. This is very easy model, but very strong also to assess the ability of people and their acceptance of change. And this model can be done not only for the employee or for a physician or for nurse or for blood bank. You can also do it for leaders themselves. Do they understand the change? Do they really understand what is for them in that change? So you can do this analysis, and simply you can come up with the numbers as well. So these numbers, you can plot it in a shape and this graph, and you can see how much each individual scored in one or each one of these 5 elements. The importance for this is to define what is called a barrier point. So if you are, for example, now I'm doing this ADKAR for our leader, let's say for one of our leaders who is involved in change in implementing of hemovigilance, and I find that actually he scored 3 in awareness. That means I have to do something. I cannot go directly and to explain to him the next step. We have to treat the problem at this stage. So any number, any score, 3 or below, that means it's a barrier point. You cannot achieve the change. You have always to go and go back and try to solve the problem. I'll just give a quick example just to make it easy for people to use this adhkar. I advise really to use it even in your life, daily life. For example, if you want to, if you want to change, to lose weight, for example, this is a big change in some body lives. And I have my son who should be here, but he didn't come. I wanted really, he was 130 something kilo, and he really moved and changed to now almost 70 something. Without operation, no, alhamdulillah, everything. But what he has is this, the adhkar model. Of course, he didn't know that it's adhkar model, but what he had first the awareness. He know that he need to change. This is not healthy for him. It's not good. He cannot play score. He cannot do what other peers do. So that's the awareness. He need to do something about himself. Then he moved to the second step from the awareness to the desire. Now he has the desire. Nobody, even if I ask him go and do some exercise or go to do this, he will never be. He himself has the desire to change, and then he start looking for how to do it, the knowledge. So he had to go to the gym. He has to do. He asked his brother, who is also a nutritionist, he asked him to make him like a list of how much calories he should eat, and he's stuck to that. And then it's actually the ability. He went to gym. He tried to do all these exercises to make sure that he lost weight, and also now he sustained this. He reinforced. He doesn't eat with us. He don't sit with us on the table for dinner. He eat alone, just not to spoil his system. So he's really at it. So this is simply, if you want to know where is the barrier point for a change, just apply this one, and you will find that, yeah, I'm good. I have awareness. I have the desire. I really want to change, but I don't have knowledge. So at this stage, okay, go and read more, understand how best way to change. Let's say I have a knowledge, but I don't have actually the ability. I don't have time to do exercise. I don't have time maybe to read. I don't have time to change. So this is a very simple. So adhkar model is very, I like it because you can apply it either on the level of like hemovigilance, but also you can very simple apply it even in our life. The dangerous thing, or the good thing with also this model, that people can go forward and backward in this. So you can, one day your barrier point is the knowledge, but you work on that, you give training, like in our situation, hemovigilance, we give a lot of training, like this workshop, everything, but people will move to the next step. After a few months, they will go back, maybe 2 steps back. So always this is why we have to keep doing this assessment regularly in any project that we are planning to implement, to make sure that by the end of the project, everybody is on the full understanding of this outcome of the change. I don't know how much time I still have, but please warn me if I'm going too late. Okay, resistance of change. This is a very huge topic, and I'll just touch on it very briefly, because we have seen since morning there are a lot of examples of very excellent, I would say, trials to implement hemovigilance in Egypt, in other countries, Saudi Arabia, Qatar, everywhere. They are doing their best to implement an hemovigilance, but I think it's not happening so far. So simply by resistant could be in the form that Dr. Maha also explained, underreporting. Why people underreport this incidence? So this is part of resistance, but resistant is more large picture we need to understand from the change management perspective. So we have to agree first that resistance is a natural reaction to change. This is very basic thing. We have to accept it. We should not be surprised of the change, of the resistance. It's a nature of human being. It's also there everywhere. Whatever you do, there is still some degree of resistance. But who's the most resistant group of our, like when we talk about hemovigilance in our mind, who's actually the most resistant people? Usually from the research, and the health care organization or other non-health care organization, you find that the middle managers is the most people who resist the change. You have some resistance from the leaders. You have some resistance from maybe the frontliners, the people on the reception, the people who collect blood, the people or the nurse. But the manager is the most resistant people. This is why we need to pay special attention to them when we are really assessing our successful implementation of a project. This is just the sign and symptoms, I would say, for resistant. How to identify the resistant. Sometimes you know that the resistant is simply, I don't want to report. I'm very busy. I don't have time. Why I'm doing this? All this thing has been discussed by Dr. Ma. But there are a list of things. It could be the emotion, the fear of change. I don't want to, I'm not really happy with what's happening, going on in this situation. So that could be a resistant issue. You know, there is also the work impact. I may lose my work. You may bring another manager, so I lose my position. All this, although it's very simple, but very critical. The good thing with using a change management strategy, each one of this could be tackled and also has a plan to correct them. So it's not always that you should punish or take the discipline, action, but there are a lot of things that you can do before you reach that stage. This is just to show you some summary of why we have a resistance sometimes from the employee point of view and from manager point of view. From employee, usually it's lack of awareness. So when we talk about ADKAR model, the first one is awareness. If you want really to make sure that the change is successful and to implement your project successfully, you have to always pay a lot of attention to awareness. Awareness of leadership, awareness of people involved in the process, and awareness why we need to change. It should be clear for everybody. And also the change rule. Sometimes I'm happy with what I'm doing now, but my manager, if I agree to this change, he may add some more jobs or tasks for me. So that may not be actually a good thing. So I'll start resisting this. So how to manage the resistance? The first thing, we have to agree that it is there. It is manageable. The good thing, it's manageable. It's not something that we don't have. We have to accept it. Of course, we have to accept some degree of resistance, but at the end, we have to have a systemic approach for resolving this type of resistance. If we don't, we'll be frustrated. And I've spoken to many friends, like, as a manager, I do a lot of things. I spend hours in the work. I make good forms, I make lectures, I explain every small bits and pieces, I write procedures, but why my employee is not following what I'm asking them to do? This is not because you are bad or they are bad, no. It's because they have resistance, and you are as a manager, you have to be aware of this and to know how to analyze it and then how to solve it. So just again, from ProSci point of view, there are two type of resistance, either or the approach to avoid resistance. The first thing is to prevent it. If you have a new project you want to implement, you have to consider and you appreciate that there will be a resistance, so you have to work from now on that. Use ADKAR model, make some changes, get people engaged, ask about, make open communication, make the leadership speak loudly so that everybody believe that this change is for their good, not will come and cause them problems. And also sometimes you end up with a resistance that you cannot actually prevent, and you have to manage, which is the other type of resistant management. ProSci methodology suggests 10 tactic or strategies to manage their resistance. I will not go in details, but it's the first important thing in my opinion is that to listen and understand objections. Why people object not to do this? Why people not reporting? And Dr. Maha in her presentation showed that there are some examples or reasons for why people not reporting, especially physicians. Why physicians think they shouldn't report something like that? So we have to sit them, explain to them, give them awareness about this, what they have on this system if they change and increase the reporting. Also, we remove the barriers. Usually the barriers could be technology. How many staff, they are really good in using the IT? You have to keep teaching them, make sure that they're competent in what they're doing. Training itself is not a solution, in my opinion. You have to always train people, make sure they they understand and they can use this training in their work. Because sometimes we are just say we have trained and we give signature of the training and we go home. This will never solve the problem. You have to make sure you have to measure the competency. And also, one of the things also you can also, you always show the benefits, show other good example, other successful changes, successful experience. Like every time I show myself, every time I see short report in Twitter, I wish that when we should reach to that. This is very inspiring, thing for I think in the field of hemovigilance. So this is good to show people, especially leadership, middle managers, that with reporting and changing and adopting this system, we'll end up with all these benefits coming to not for the patient but also for the organization in terms of cost and also repetition. So in summary, implementation of a national hemovigilance system is a major change and therefore must be managed effectively both at the technical, having a very good, well-designed project management, and also on the side of people. Do not ignore the importance of the comfort of people. Always think about people as a major contribution to any project that you have. Effective management or change management would ensure successful and sustainable implementation. You don't want just to have a sustainable change, but you want that to be, you don't want just to have successful, but you want also a sustainable change that can be resist and you can build on your success. Organizational change comes from individual engagement, adaptation, and use of the change. You cannot have an organizational change like what we have now. And if you want to have a national hemovigilance program, do not think you can have this if you have gather few people and design some good system and you say, that's it, now I have a hemovigilance. No, you have to ensure that, I don't know how many people working in blood bank and transfusion services and hospitals to be changing to where you want them to be in terms of having this. And I end up with just a phrase from Al-Quran Al-Kareem, قل الله عز وجل إن الله لا يغير ما بقوم حتى يغيروا ما بأنفسهم. This is very critical. This is very true for everybody. We cannot change unless we are embrace the change himself. We cannot be, we cannot implement hemovigilance or any other thing, even national blood service, if we don't believe that this is what we need to do. We have to believe in ourselves, then we have to work together to achieve the picture at the large. And by this, I'd like to thank you very much for your listening.
Thank you, Dr. Abdullah. And our last speaker, Dr. Anna Flynn, Director of Australian Commission on Safety and Healthcare Quality. If you can start, it will be on video for maybe 15 minutes.
Hello, my name is Anna Flynn and I work at the Australian Commission on Safety and Quality in Healthcare. I'd like to thank you very much for inviting me to come and present to you today. And before I do so, I would just like to acknowledge the traditional owners of the land on which I am on. Now that is the Gadigal people of the Eora Nation, and I'd like to pay my respect to their elders past, present and emerging. Now, for many of you, you might know these lands as Sydney in Australia. And I'm going to talk to you today about work that we do at the Australian Commission on Safety and Quality in Healthcare around an area that we call partnering with consumers. So hopefully I'll be able to share some insights about the challenges and best practices and hopefully help you further in the way that you're able to approach your own work. This session will provide an overview of the National Safety and Quality in Health Service Standards work, specifically the elements of partnering with consumers that form part of the blood management standard. We'll look at examples of high-performing, person-centered care and how to involve consumers to improve health service outcomes. For those not familiar with the Australian health system, I'll set the scene. One of the key drivers for safety and quality improvement in Australia are the National Safety and Quality in Health Service Standards. The standards were developed by the Commission in collaboration with Australian governments, the private sector, clinical experts, patients and carers. And these particular standards were chosen as there was evidence to demonstrate improvements needed to be made. The primary aims of the standards are to protect the public from harm and to improve the quality of healthcare provision. They provide a quality assurance mechanism that tests whether relevant systems are in place to ensure expected standards of safety and quality are met. As you can see, one of those standards specifically relates to blood management. You'll also see the second standard is partnering with consumers. In a moment, we'll have a look at how the two intersect. So here's a bit more information about the blood management standard. Each standard has a set of actions relating to it, and health organisations are accredited to these actions. So the blood management standard has 10 actions that aim to improve outcomes for patients by identifying risks and using strategies that optimise and conserve a patient's own blood, as well as ensuring that any blood and blood products that patients receive are safe and appropriate. Now you can have a look through our standards to see the full 10 actions, but I wanted to focus here on action 7.3. So action 7.3 intends that patients and carers are informed about patient blood management principles, the risks and benefits of using blood and blood products, and all treatment options. So specifically what this action is saying is that clinicians are to use processes from our Partnering with Consumers standard when providing safe blood management. So this actively involves patients in their own care. It means meeting the patient's information needs, and it includes shared decision making. So we'll have a look at the Partnering with Consumers standard and what processes clinicians should use to involve patients in these planning and decision-making activities about safe blood management. The Partnering with Consumers standard was developed as there is good evidence that delivering care that incorporates consumers' needs and preferences can lead to better health outcomes, better experiences, and greater efficiency of care. When healthcare professionals, healthcare managers, and consumers work in partnership, quality and safety of healthcare improves, adverse events decrease, healthcare professional satisfaction increases, and patient care experience improves. Partnering with Consumers standard aims to ensure that consumers are partners in the design, delivery, and evaluation of healthcare systems and services, and that patients are given the opportunity to be partners in their own care. The Partnering with Consumers standard has specific actions related to health service organisations' processes for involving patients in their own care, shared decision-making, informed consent, and effective communication. Notably, the standard describes what needs to be achieved, but not how to get there. There is no single best practice approach, and there are many different strategies and approaches for effective partnerships. So how do we bring together the Partnering with Consumers concept with the blood management standard? Some of the strategies that have been used in Australia include providing information to patients and their carers that includes all treatment options and really explains the risks, options, and the benefits to that care. And then importantly, it's making sure that this information is provided in a format that can be understood and is meaningful, so that it ensures that patients and their carers are given the opportunity to ask questions. So ensure that the information is current and that the clinicians have ready access to it. And the information needs to be able to suit different people with different levels of understanding. We call that health literacy here, but it means making sure that sometimes more simpler information is provided and that clinicians have access to the most appropriate information for that individual patient, so Sometimes that might require information in different languages, information that's written or diagrams, and perhaps sometimes information online might be more appropriate. And where local information and resources are developed, it's good that these include the patient and the carer in developing the resources that makes them more meaningful and make sure that it's more understood to other people. It's also very important to ensure that organisation-wide informed consent processes are included and consideration of issues relating to a particular consent for blood transfusions. It can be helpful to focus on what we call person-centred care, really focusing on that individual person. Person-centred approaches and strong partnerships with consumers are what we consider to be critical in achieving better health outcomes for communities and better value for health services. Here you can see 7 key attributes of person-centred healthcare organisations. And if you head to our website, we've published a report showing examples of how to achieve each of these attributes. Based on this report, we've developed some case studies that highlight good practice examples and aligned with both our Partnering with Consumers standard and the 7 attributes of high-performing person-centred healthcare organisations. The case studies demonstrate a range of different approaches to health literacy, as we discussed earlier, consumer engagement and shared decision-making, and they show that each organisation is on its own journey and must determine what works best for their local communities and for their service delivery context. We're also about to release a guide for health service organisations to share with consumer representatives or potential consumer representatives who support safety and quality activities in their health service. The new resource helps you work towards a more genuine partnership with consumers to improve all aspects of health service delivery. It helps consumers to know how to better communicate and partner with clinicians and health services, improving their own care, as well as health services more broadly, and to understand how they can become consumer advocates or consumer representatives and what they can do to influence change. It also helps those that are already consumer representatives, advocates, advisors, members of consumer networks or organisations, and would like to understand how the Partnering with Consumers standard can support them. The Commission has developed a suite of resources available to assist health services to implement the standards. They're all available from our website. One of those resources is our standards monitoring tool, a really well-used tool, and it's developed to allow health services to track their progress against implementing each standard. We've developed some tools and guides specifically to help with partnering with consumers. One of those is our Australian Charter of Healthcare Rights. The Charter sets out 7 clear rights that describes what a consumer should expect when receiving healthcare. This Charter is required to be displayed across all health services in Australia. To support shared decision-making, the Commission has developed a 2-hour online learning module. This is for clinicians to help develop and refine skills in communicating effectively about the benefits and risks of treatment options with consumers. This module is called Helping Patients Make Informed Decisions, Communicating Risks and Benefits. We've also developed some resources to help with health literacy. One of these is called Top Tips for Finding Good Health Information Online. This came about during the COVID pandemic, when consumers were having difficulty finding good quality health information online. We've developed a poster, a booklet, and an animation. We're working on a project at the moment to develop a guide for consumers that are actually working within health services. And this is to help them understand what their role would be in that health service, particularly around the Partnering with Consumers standard. And finally, we're about to launch some new webinars. We're looking at developing webinars based on real-life examples of health services delivering person-centred care. and would very much like to invite you to take part in those webinars. I hope this presentation has been useful. If you have any questions, please don't hesitate in getting in touch. The Commission is accessible through a number of channels. Please go and explore the resources that we have developed, and I'm always very interested to hear what other people are doing in this space, so please get in touch. Enjoy the rest of the event. Thank you. Hello, my name is
We'll conclude our afternoon session. I will ask Dr. Abdullah Maashi, Dr. Maha to join at the podium for any further question. And I heard we have tough audience. In the morning, we were hammering with the question. So any question? So I will start my first question. Hemovigilance, it's from vein to vein. And the Saudi blood transfusion services in general, majority of the hospital did a tremendous work in improving the donor selections and even during processing the blood products. But unfortunate, once this unit of blood release from the unit, we didn't know what's going on with this. Very poor reporting. Even in the literature, years ago, I did some, what we call it, biometric analysis, scientific methods to go for mainly for the research. And I want to know what happened to this unit, what's been reported in Saudi Arabia. Unfortunate, we don't know about transfusion reactions, nothing. Even for the collecting the wastage of the unit, what happened to this unit, what the nurse did in this unit. In your opinion, you show us a lot of obstacles, could be, but how we can in real life, how we can offer it? Dr. Maashi?
I think this is, again, it's missing all these things simply because we don't have a national hemovigilance program that everybody knows the role that he should play in. So, for example, now we are, even in, I think in Ministry of Health, if Dr. Hind and Dr. Mona has corrected me, but I think the people who report this reaction actually is the blood bank, not the medical team or the nurse or the health practitioner on the ward, where patient actually develop this type of reaction. I think it's a long journey. It's not something easy. I know it's, as we again heard this morning, for UK it took more than 25 years just to reach to a national reporting level. So I think it's the first step. I think we need to understand and to be aware of the problem, that really we have a problem. We admit this problem, we analyze it to see why it's happening like that, and put the right solutions. And with the support of leadership, I think we can move to a better situation.
Dr. Maha?
Absolutely. I think the road is still long in front of us. Alhamdulillah, we are on the right track. But we still have to work on lots of things, starting with policies, procedures, definitions, learning from others, developing the perfect or close to perfect reporting system that users love to report in. And again, in general, emphasizing the just culture in every single interaction we have in our systems, from the smallest, the lowest level between employees themselves, employees with their supervisors, supervisor with hospital administration, and then with even superiors. Just culture all over. I think that's key, inshallah, for having a better reporting around the system as a whole.
Can we learn from the UK experience? They took 20 years, but we can make it shorter because we're not going to invent the wheel again. But we can learn from their experience how we can get it shorter and reach faster for a majority of audience. Both of you blame the clinician. and nurses, and I am a clinician. How we can improve it? Because before I involved in the blood bank, I never realized the obstacles or importance of reporting. Can we reach them more often? Because, and I feel blood bank, usually they are working aside, although they are the cornerstone of the blood of any hospital, but yet they are working and they are in the dark. They are the hidden soldiers. How we can improve? Do we need to go and more communication with them, interact for those who are always in need of blood transfusions, cardiac surgeon, oncology team, hematologist, trauma team, emergency department to be involved more, and let them be a part of our hemovigilance to realize the importance of their feedback with us.
Maybe I'll take that as a clinician too. So as a clinician, as a hematologist, before joining the transfusion medicine field, clinicians have very little education about quality and safety, unless it's forced on them or if they have that initiative from within. Okay? But it's not really something that's embedded in their curriculums. So knowing, learning the terms, corrective action, incident reporting, near miss, honestly speaking, I think you will rarely find a clinician who is not involved in the laboratory one way or another who is familiar with these terms. We need to do a better job, honestly. We can actually collaborate with the patient safety and quality departments in hospitals, because we share the need for incident reporting. I think this is shared among all, both of us. So we need to utilize them. Continuous education is something that Dr. Aisha focused on. Something I recognized recently. Sometimes we teach a department or give a lecture to a group, and then we get frustrated. Why are they still doing the same mistake? Well, people change, and they rotate, and house officers start, new house officers start, and people retire. So the journey of education to clinicians is going to be a continuous thing. I'm very hopeful one day, inshallah, that we have an online sustainable transfusion medicine curriculum for clinicians. There are modules in the Saudi Commission for Health Specialties for residents, but I don't know how deep they go. Maybe inshallah we can work together on something that is available for everyone, so every clinician can have access, every nurse can have access to essential safety information, and understand how the reporting of incidents and reactions can help other patients.
Yeah, excellent idea. At King Saud, we introduce blood transfusion medicine from the third year. It's 1 week. The student, they have to be familiarized themselves with the transfusion medicine. What is it? But hematology, they take it, anesthesia, cardiac, but maybe we are not emphasizing when they are doing the rotation in blood bank more about the hemovigilance. I totally agree with you. Any question? تفضل.
Assalamu alaikum. Thank you, Dr. Maha and Abdullah, for the very interesting presentation. Actually, my question is about, or maybe the comment. One of the resistance causes is that as a end user, we don't have access to the data of the hemovigilance program at the current situation. We cannot see how many reported reaction for the donors or the patients. We cannot, it is limited access, so we cannot touch the benefits. Of course, if we have whole numbers for the country, we can see how did they do, what was the solution, what was the corrective action, how frequent donors having such problem. So because of that, reporting is not that strong as we have, if we compare it with shot. As you know, every time every month maybe, or every year, they have a very excellent report. So we can see as an end user that how many donors had that reaction and what did they do to implement it here. I think limited access to the data is one of the resistance causes.
Excellent question.
If I just comment on this, Abdullah, you're right. I mean, and this is one of the issues that we need to change, is to have the right reporting and also to share and disseminate the outcome of those reports. But there is also one major issue that I may really need to pay attention. Dr. Maha said that understanding of hemovigilance is very important, either for physician or non-physician. As a non-physician, I think dealing with physicians is difficult, but it's easier than other group of health practitioners, I promise. Because I have been in many situations that if the physician understands the importance of this to the patient's safety, he will embrace it, he will do it. But other non-physician or non-technical, or it's difficult to convince them with something that it's a quality measure or KPIs or something. So I think sometimes I do like evaluation for blood bank staff who are coming to be classified as seniors. And I tend to ask them one question about hemovigilance. More than 90% of these who should be classified as a senior blood bank specialist do not understand the hemovigilance. So why I should blame physician or nurse? So I think we have a huge gap knowledge. And this is again part of the change. You have to consider it. You have to raise awareness. You have to make sure that the knowledge is there, that the right tools is there. So it's very complex, but it's manageable, I think. It just need time and effort.
So what you are suggesting that we need to involve clinicians and to be more compassionate what we are doing.
Yes, that's important. I have a personal experience with the hospital transfusion committee. Sometimes no physician is attending. This is very, I don't know if somebody, they don't attend. I find myself and the nurse the only one sitting. Then the medical director said, okay, make OVR. I said, no, why we should go for OVR? It's not the right solution, in my opinion. So I start talking to each of the departments and ask him, I don't want the head of department to be represented. I don't want you as a head to be in that meeting. Go and see what you want to do, but give me somebody who can sit with me. And alhamdulillah, we have now good attendance rate compared to what we have previous. So I think it's just talking to people, communication and engagement more than anything else.
So, and I will share my experience about other departments with transfusion committee. What I did to them, usually I will do like an audit in cardiac surgery, then I will see the defects, then I will ask for a meeting for all the cardiac surgeon, nurses, and present our data. Then we try to improve with them. With the frequent education, it's not only one visit, like in frequent education, update them, what happened to the previous agenda, we agree on it. They are in continuous involvement with us in the blood bank. Maybe this will improve the quality. We had some surgeons, just for their their comfort, they will ask for 1,000 of units. I think all of us experience, just to keep it there for them in case. We reassure them, we did audit, we improved the wastage, we improved the care of the patient, and they felt happy about it. And even in one project, the duration of ICU was less, with less blood for those patients, and they did a study about it. But I think to involve them and let them their sound and their practice make change on the patient before it's in the demand of the transfusion make a big difference. Any more question? تفضلي.
Yes. You can hear me now? Yeah. Thank you very much for your both presentations. It was outstanding. And I would like to attract the attention of all of us. Through the whole day today, it's pretty much obvious that we in blood services know very much every information. We know very well what is supposed to be done. And we all agree that the clinical side, they have very little information about whatever is happening in our side and what's the importance of hemovigilance or reporting or anything going on beyond the scenes to produce these very valuable products for them. We all now know about the resistance and I mean all these nice things, but I think we in our side are still not doing the good job that we are supposed to do. We have to be more proactive. And don't forget, it's a fact of life that people on the clinical side, they feel very much superior on the people on this side. This is a fact of life. So we need to reach out, impress them, and make them really believe that we do have same level of information and useful, I mean information and service, up to their standard. And I think part of this proactive activity, if I may share my modest or humble experience in the past, when I realized whatever we are complaining about today, I chose a small group of people in my team who are very well presented, and they can speak well, they can transmit the information in a very clear and convincing idea. I trained them to be good speakers in events of the other clinical side. And we prepared as a team several lectures with references, with numbers, with pictures, clear and attractive. And with our personal communication, and we all have friends in all fields, okay? We used to approach them and convince them to give us the opportunity in their national congresses or regional congress or even at a hospital event level. And we used to ask them, please give us the chance to give one lecture or give us one session of 3 lectures if they have a 3 days event, for example. And we used to just protrude to them and embark on them. And month by month, year by year, we were very much visible. And people used to respect us, used to listen to us. And then we used also to invite them in our congresses. For example, like this today, one eminent clinician can be invited as a speaker and talk about blood transfusion from his perspective or her perspective, and let him stay the whole day and listen to all of this. So event by event, day by day, things can be normalized between this side and this side. This is just a glimpse of a very humble experience. Oh, and if you are also ready with the guidelines, whether it is your national guidelines or the WHO guidelines that is acceptable by everybody, you can disseminate the website where they can find information in it. And I hope this is useful to you.
100% agree with you. And in our unit, we did something called the transfusion education unit, and we did exactly clinicians with excellent technician معاه to answer, and we invade them. Continuous. Absolutely. Dr. Mana, last question. Dr. Mana, last question, تفضل.
I would like first to thank you all for the excellent presentation, and also would like to thank the sponsors, Dr. Hind, for her excellent, setting this beautiful event. For a new transfusionist and for the new generation, it's for the speakers and also my guests. What can you give us as an advice for a new transfusionist? What can you add to us? What advices would you recommend it for us?
For me, I would say be patient. be ready for lots of difficulties. Well, every field has difficulties, but our field has some very interesting challenges that you really have to be on good relationships with everybody in the hospital. As Dr. Fatin emphasized, you really have to have excellent relationships with every department. I'm not saying you have to fulfill inappropriate requests, but they have to know that you're available for them and they can reach out to you. And that you can also reach out to them when you see abnormal trends, or if you would like to present an educational lecture, or so that's for me. I thought maybe being patient and resilient and not surrendering, and knowing that the education in the hospital, if you're working in the hospital, that educational journey is continuous. It will never end. Never say, already said this before. You're going to have to say it again. Dr. Abdullah, do you have any other advice?
No, it's just about, can you hear me? Okay, it's now working. Okay, it's just what Dr. Fatin said, and everybody said actually. It's there are a lot of experience and good things we can do to change the current situation, but in my opinion, we need to do that systematically, and to be able to do this change, we need somebody who's trained in change management. I mean, I know it's a new discipline or a new thing in the way we tend to do things, but I believe that actually after I get at least my training in change management, things change totally, how I deal with things, both in my personal life and also my professional life. And imagine if I have in each hospital or in each institution people who are trained in change management. They understand the resistant, they plan for the resistant resolution, because I didn't have time, but there are a lot of tools we can use to have a written plan, how to turn Dr. Maha to somebody who embraced the success. It's not just by our feeling or what we have experienced. It is very important, but there is a knowledge behind this, a knowledge behind people behavior. So, we can see that it's about human, not about as Dr. Fatin said, we know everything in hemovigilance. We can lecture now in hemovigilance, most of us. But when it's come to the work, it's totally different story. We have people who resist, not aware of why we should be doing this. And I think this is another part we need to encourage. Change management is important, and we need to make it as part of any project management we have.
As a young practitioner in this field, please be passionate about your specialty. Please love it and make sure that we are lucky to be in this field. You know why? Because our specialty is not just one field. I divide our specialty into three main fields. Clinical field, clinical medicine, laboratory medicine, and public relations. This is very nice formula, and it won't make you bored anytime. Public relations, because we are in charge of recruitment, motivation, retention of donors, and this makes you engage with media, with the celebrities, with the people, normal people. And this side is by itself very motivating to ourselves. And then laboratory medicine is another very beautiful field when you test and you get results and you challenge yourself with identifying antibodies and all these things that you know about. And the third field is when you really consult on how to use blood components, how to handle a reaction, how to treat, when to stop the treatment, when to increase the dose or decrease the dose. So I feel that we are really lucky. We have this mix of three nice fields. So please be passionate about what you're doing.
Yes.
Okay.
Just 1 minute, please.
Okay, go ahead.
I would like to more clarify what Dr. Fatin said, which is that transfusion medicine. I think we should work on this subject as a separate specialty in the medical training. So it should be given the priority that, because if we regard the transfusion medicine as a separate specialty, most of this difficulty will be resolved. And I think this should be taken at the level of the Ministry of Education and Ministry of Health. Transfusion medicine, postgraduate training in transfusion medicine is very nice subject, as Dr. Fatin said. With regards to the hemovigilance, I think it's very difficult even in most advanced countries. Whatever we do is good, and as long as we are talking about and starting step after step, I think we are doing a good job in this field. Thank you.
Okay, at the end of this great session, I would like to thank Prof. Al-Qahtani for chairing this session, and thanks for all the presenters in this session for their outstanding presentation. Now we're not going to have a break. I'll kindly ask Dr. Abdullah to stay on the stage to chair the next session for the panel discussion. Meanwhile, I would like to ask you a favor. Can you give us your feedback about the workshop for the first and second day? They are in the QR code. If you scan the code, you'll get 3 options. The first option for our distinguished guests, the second option for our attendees who attended on site, and also the third option is for the online attendees. So we would love to hear from you. This is going to help us for the next scientific activities. So we'll give you time to scan it, and we would love to hear from you. Any comments, anything, any recommendation will improve our work. So I'll give it a while, then we'll move to Dr. Abdullah to start the next or the last session. For myself, there were 2 wonderful days for you. I didn't want to finish them, but this is the schedule. I really enjoyed it. I learned a lot, and we were given like a great honor by Ministry of Health to co-organize this workshop. Thank you so much. Thank you, Dr. Hind. It was a great pleasure for us, and I hope we did good work in this workshop. Thank you so much.
Thank you very much, Dr. Mohammed, for this. Before the end, we would have a panel discussion about how we can establish a national hemovigilance program. So I'd like to just ask the following distinguished speakers and the leaders to join me on the stage so we can have this panel discussion. Dr. Fatin, please, and Dr. Hind. I don't know if Dr. Abdullah was online, still with us or not. Dr. Aisha and Dr. Muna, if still there. Okay, so please.
Can I mention one thing, Dr. Abdullah? I think today we had the luxury of time, so we had 2 good discussions between the lectures. Different from yesterday, we didn't have any time for discussion and questions. It was all at the end. So the idea of this meeting now, just to wrap up and come with some recommendations how to apply a hemovigilance program in a country. We understand from all the talks it's very difficult, very complicated, but there is no way back. We have to keep going to the front, and we have to do it. So that's the idea. I think there was lots of healthy discussion. Yesterday we didn't have time to discuss. So we'll just 10 minutes continue the discussion.
Allow me, Dr. Hind, just a quick announcement for our distinguished guests who are going to stay with us tonight. Dinner is included. Just order it, and will be provided.
Thank you.
Yes, I'm leaving, Dr. Ali, Dr. Mohammed. So can I have a takeaway or? Okay, good. Thank you.
Thank you.
Okay. Can I ask also Professor Salwa also to join us, please?
Join us here, please.
Can you join us, please? Please. Okay. Okay.
I would like to mention one thing, my impression from the day about hemovigilance. It is not easy, but the conclusion, I think everybody is looking for a perfect system to start. And we can never, never have this perfect system. And I think whatever we have, resources, we should start. And even if it's not perfect, it could be done on stages. And as we go, we will get things refined. But I think, I was just thinking while I was on the chair, we have to start to have a perfect situation, perfect setup, perfect system, perfect coding, everybody's trained. I think we can never have this ideal system. That's my impression.
Absolutely. And be proactive. Yes. We have to do something. Don't wait for others. Don't wait for others to pave the road for you. We have to pave it for ourselves. So on the hospital level, where we are, we can make sure to activate any hospital transfusion committee or establish it from the scratch and make it active. And just engage yourself in the continuous education in your hospital and put yourself inside with your lectures. And please avoid lectures about hemovigilance. Like straightforward hemovigilance. Take lectures about transfusion in pediatric settings or neonatal settings or massive transfusion. Be cunning. So be impressive with what you know about the actual medicine, and then they will be attracted, and then you just put the hemovigilance ideas like drop by drop inside whatever you are doing, okay? Because hemovigilance, by definition, is a burden on them. They have to report, they have to admit that. So put it inside whatever nice talk you are going to do.
Can I start just asking a question, and it's good for discussion, you know. Let's say I'm not in the field, I'm coming from outside, I'm a physician who's a surgeon. I'll ask you a direct question. Why do we should have hemovigilance? I cannot see any benefits. How you would actually convince me that hemovigilance is important? And you want me to keep reporting a lot of things and to take a few minutes from my precious time to do this. So we have to have a case, business case, that really it's important. So how do you answer me, Dr. Fatin or Dr. Hind, Dr. Salwa? How do you convince me that hemovigilance is something important? I'm talking about we lack a lot of things in medicine. We want to improve the surgery time. We want to do a lot of things. We have a trauma situation. We have epidemiology. And now you are coming and talking about hemovigilance. What is hemovigilance? I don't have time to listen even to you. So how do you convince me?
I will let Dr. Salwa comment, but I can say one thing, Dr. Abdallah. Pharmacovigilance is there for a long time. You know, we know that every drug has side effects, and there are patients, sometimes they die from drugs or they have side effects, and part of the practice of the pharmacy is to report side effects related to drug. Any drug has side effects. Blood is a drug. A patient can die from blood. Patient can have severe reaction from blood, and they can have mild reaction. So hemovigilance is like pharmacovigilance, but it's just, it came like way after medicine. I don't know why. The pharmacovigilance has been around for a long time. But the hemovigilance is relatively new. Whether blood is a drug. So it's the same. That's my answer to you. You're giving a drug to a patient. This drug can kill the patient. The patient can go with side effects that you can detect not now, after years. So you have to have a system of reporting it and improving the safety of this product. Dr. Salwa.
It's good? Yes. In short, you can say convince them. How to convince them? You have to show them their data, their own data. What's going on in their departments. Show them statistics, show them what is the result of these statistics, and just ask them that these statistics need to be improved, and it is yours. You are working every day in the theater. You have a lot of data which show that it doesn't need to order all this blood. As example, if you show them the data and you convince them, they will go with you. But if they can't see real things and local basis, they will not. You can also discuss with them examples of others, but they need to see what they are doing. And if there is a space or place to change, they will not say no. But if you are not going to them yourself and discuss with them and show them their data, it will be difficult to convince them. And I leave to Dr. Fatin, she wants to also to...
Yeah, I add on Salwa. You complained that when you go to the committee meeting, you find yourself only with the nurse. Don't get frustrated, because many other data comes to you. Like, for example, how many transfusions were ordered, how many transfusions were already given, how many blood bags were used in the same operation but by different people. You know, of course, all these things that hospital committee is after or about. And create this data and these statistics and send it back to them in a nice email or a nice report, and attract your attention, their attention, by giving them statistics. And it will always be good to make some recommendation or advice on the end of this report. I advise you to do so and so, or whatever, about also how much storage time in the wards. So you still have the data and the information. Information is power. Once you show them that you have information, slowly you will show them that you have power also, and you have something to add on their experience. Then ultimately, you are going to get there. And don't forget that also one of the definitions of hemovigilance is the ultimate step of quality, which is true, because we have this very extensive quality system in the GMP culture until you produce this product. And then finally, it goes out of your door, goes to the patient, inside the patient. So the ultimate step is, what did it cause to the patient? Did it really benefit the patient or harm the patient? Slowly convince them that it is for your own sake, for your own reputation, for your own glory, that we need to improve this activity, and we need to be with you together to enhance the transfusion effectiveness and value. I think, as Maha mentioned also, we have to be patient and resilient, and after them. Again, don't forget that you are in a very powerful position. You have some data that belongs to them.
If you can... I totally agree with everyone, and I will answer you from a clinician perspective who order a lot of blood. So you need to talk to me in the same language, because my focus when I am treating my patient is the patient care. So you need to talk to me in the same language, that I am harming my patient, or my patient when I am ordering is not benefit. As most of my colleagues mentioned, that data show me I'm harming my patient when I order such a product, or I'm harming them by ordering the wrong products for this patient, or actually I'm doing nothing to them by ordering such products. So talk to me the same language, patient care, rather than to be numbers. Okay, so what? You can talk to me like the wastage, so what? You can talk to me about we have difficulty in donor, we need to prioritize this patient to give him such a product. But talk to me, because my focus is this patient. Now I need to save him. I think I am helping him. With your data showing that I'm in harm to this patient, maybe you will start to convince clinician more.
Shukran, Abdullah. Here I will not talk about how to convince the physician, but there is, and about the change management and the time and the patients, I would like to talk about practical solution, which I used in my hospital. Actually, I try to find the key people. You have to find the key person who can support you. First, I tried with the transfusion committee. There was a lot of physicians, and they understood clearly what is the hemovigilance. I met last week one of the presenter in Jeddah's conference, and they implemented the patient blood management, very successful patient blood management system in their hospital. And I asked him, how did you manage to implement it? And you know, his answer was almost similar to my approach. He said, go to the head of each department, all physicians, head of physician, sit with them, tell them, explain to them what you are doing. And from then, from top to down, not from down to top, go to them, explain to them the heads of departments, and then start to, from them to convince or to talk to their groups. And you can also assist the group by giving presentation. So this is a faster, I think, way to implement. I'm talking about hospital, but not at national level. Maybe to all hospitals to be implemented, but this is a one way to implement the hemovigilance.
Dr. Abdullah, you mentioned a very nice thing in your talk, which I captured in my mind. People, you know, they really resist change, but the mid-managers, the managers in the middle, not at the top, not downward, in the middle. Yes. They are the ones that, this is from my experience also, they show most resistance.
Yes, yeah, even from science.
And I think because they think they're going to do most of the work, you know, that's why they show resistance, because at the top they don't do much. They tell, you know, like, you do and do this, you go and do this, you go and do that, and they take the credit. So how can we solve this, those mid-managers?
Yeah.
How can we reduce the resistance?
Yes. Again, there are many tools, but one of them is reassurance, because one of the fear that they have, either they will get more work to do because they are responsible for many tasks as the managers, so they don't have time maybe to do what you want them to do, or they are worried to lose their positions sometime, because from their inside they have the fear of they will not be able to cope with the change. They don't know how to deal with this situation. So the best way to do things, I mean, there are type of resistant and sign-up symptom. One of them is the silence. When you talk in a meeting to start some project, if you find somebody in the team who's just sitting in the corner, not talking, not engaging with you, that's the sign of resistance. He's confused. He doesn't know how to do. So the good thing why these people are very important to treat the resistance they have is once they embrace the change, all other employees will be easier to also follow them, because for them this is the people, this is the manager. But if that one is continue resisting with all these tools and intervention you do, the 10 things I didn't mention, number 11 was you should remove him or her. Yes. Don't waste your time with somebody who's resisting for no obvious reasons. It's not emotional, it's not fear of reassurance, it's not awareness. It's just they don't want to be in the team. So put him as a احتياط يعني.
Can I add, Doctor?
No, this is the last. In Arabic we say that آخر العلاج الكي دكتور. It's true. I mean, there is no benefit of putting a manager who is resisting, and I would expect as a leader or as a manager that the team will change. It will never change. But give him first a lot of trials, and then end up with this. This is not my first choice. It's with, yeah, exactly. Yes. Yeah, there are a lot of solutions actually. These 10, one of them is the incentives. Incentives could be, yes. Appreciate, encourage, make celebrate your success. There are a lot of techniques you can use, but the time was not, maybe we didn't discuss it in detail. But the last thing, you don't waste your time. Really, this is not something tough or not, but this is, don't waste your time in changing somebody who's totally resistant, because it cannot be changed easily. Just remove him.
Just to say one word, it is good to change, even if it is good that to change manager from time to time, give opportunities to all to work. Some he can stay for 2-3 years, the other can stay for 2-3 years. It changes with anyway.
Can I add?
I tried with some people, still they are resistant. So the only thing I did at the end, I removed them. They cannot be a part of the team because they're just a part of obstacles they are going to face. So just remove them. At the end, if I tried all, encourage him to involve him, engage him, then just remove him. That's it.
You're right.
In a nice way. You can list him in a nice way.
But if you gain, if you turn this person who's strongest resistant to an alliance with you, he will be the strongest point that you will have, because the same strength that was resisting, he will be in support of what you are doing. And this is in our life also. Yes, Lenny, she has, I think, a question.
Can I add 2 points from patient safety perspective? Actually, they are working on this point for reducing the resistance of the manager and mid-manager by empowering the frontline staff, taking the manager and go to the frontline staff and encouraging them to speak up. And they are encouraging, the first point, to encourage near-miss reporting. Because when you are encouraging them to report near miss, they feel some sort of psychological safety that we can achieve, that we discover our error, and alhamdulillah, we are not making, this is our right vigilance. So when we're reporting near miss, you explore the system defects, the potential areas of system defects. And this is a great impact on patient safety and prevention of occurrence or reoccurrence of these defects. This is the first point. Second point, which is very, very, very important, and I noticed that we cannot highlight this issue today, is the difference between outcome of passive surveillance and active surveillance. Today, we are talking only about voluntary reporting. It's represent from 1% to 10% of the actual incidents. But when we are comparing it to active surveillance results, it adds more, 20%. What is the source? As we mentioned in the lecture, from IHI trigger tool, from patient complaint, from morbidity and mortality, all these items that reported to a patient from auditing and like Sibahi non-compliance points, all these points, when you are just join them in one area, collect more than 20% than voluntary donation, and can also examine the system vulnerability and near miss area or potential area of harm. Okay, thank you.
Yes, Lenny, please.
Yes, thank you very much. It's been a very interesting discussion, and especially on your change control, which is very, it includes everything we are doing every day, so it's very interesting to listen to this. And from my experience, I think one point I want to really emphasize is the leading by example, that actually the leaders do what they say, because I've seen so many times in culture change programs in different companies that we are told to do this and this and that, and suddenly you see the leaders, oh, we were told not to come late to meetings. Why is he always still coming late to meetings? If you don't, it's the small things that matters. And that annoys then people, and it goes down into the different layers. So it's really important that it's implemented, that the leaders are engaged and come with good ideas. So I think this is one point. And the other is I work more with pharmacovigilance, which is of course the same, and it takes time. I was trained on pharmacovigilance, and I also found it terribly boring in the beginning. But over time, and you are forced to repeat and repeat. Repetition is also very important in this. Never stop training, never stop. And then you suddenly notice, okay, I have to report this. This is something that, oh, now I remember. So it takes time. It will work. Thank you.
Thank you very much. That's totally true. Dr. Fat.
Oh, sorry, can I add one more thing?
No, this is open discussion, so
okay.
Add whatever you like to add.
We all now agree that the Hospital Transfusion Committee is the most important starting point. And always we forget one important member in this committee, the person in charge of the medical records. This is a very important person. It has to be included, must be included. Usually, he or she will be with the nurse, with you, even if the clinicians don't come. And this person can extract a lot of very valuable information that will contribute to your statistics. For example, if you get from the files, when did the transfusion start? And then from your files, you have when this was issued. So at least you can calculate how long it was kept on the, it was kept on the nightstand beside the patient. And then how long did the transfusion take? Started that time and finished that time. Was it too fast? That means the possibility of TACU, for example. So from the records of the patients, you can extract information that does not come to you with the system, but I mean, being part of the hospital, you are entitled to get it. Yes. And then this will help you in having a lot of information that can be designed in a nice report, go to these people with, as I said, advice what to do. Try to attract their attention by so many things.
No, that's correct. And I just shared with you and Dr. Hind a figure, maybe if you have seen it or not. It's about the timing of transfusion. I did it in my hospital, just quick analysis, and I show it in the transfusion committee. And the reason for that, because it's the same scenario. Most of the transfusion will happen in the out of working hours. So when I did that analysis, even the medical director was shocked. How this is happening? Our policy says it's only within I said, no, 70% of what we are giving our patient is outside. So from that one, we start an improvement project to change. So you are totally correct.
It's an important person.
Yeah, digging the numbers, if you like the numbers, but many people maybe they don't like numbers and statistics.
As you mentioned, Dr. Fatin, administrative data is another source of active source for risk identification, because administrative data, especially in delayed transfusion reaction, because it's a dark area about when the patient is charged and return after 20 days, whatever. It's another important source for detection of delayed transfusion reaction.
Yeah. Okay, just maybe another we are now trying to have like a roadmap. Already Dr. Muna showed a good, future plan for how we are moving towards a national hemovigilance program. But can we hear from you, where we should start? There are also always an argument, like Dr. Professor Salwa presented that hospital hemovigilance system can be a good start, or we should go for a national hemovigilance system. Which one we should start and where we should start? Can we start both? Okay, where we are going. I think it's very important really at this stage, at least from leadership point of view, to decide where we want to go. And in my presentation, this is the success. We have to define what is a hemovigilance system and how we can really reach that stage. Tafadali, Doctor, yes, please.
Can I just give a comment from a hospital-based view for hemovigilance? I was in a tertiary care center. We have transfusion committee. We have morbidity and mortality. There is underreporting, but there is a fairly good reporting system for side effects of blood, sentinel events. The data is there and everything. But then, for you, Dr. Abdullah, in another hospital, you don't know what's happening with me. Exactly, yes. Other hospital, the University Hospital Jeddah, they don't know what's happening. So if you don't have the national umbrella, which connects everybody together on a national level, and then we will come with national reports, we will not know about the other colleagues next door. So now the problem to have a national umbrella is to have the right platform. And one of the obstacles was we don't have blood bank information system in many hospitals in the Ministry of Health. And this was a big, big challenge. Now, most of the Ministry of Health, that we have execution of the project for a blood bank information system, which will make our life easier. And we found a platform, a potential platform, and the patient safety. So I think it goes both hand by hand. But if you don't connect us at a big umbrella, then each of us will have the information just at the center level. Right. Doesn't go out.
Yes, you're right. I think I can refer to what Lenny yesterday said, that every country should have a plasma fractionation strategy. So do we really need to start from this point to have a national hemovigilance strategy, which basically a policy that where we can move from now on based on that? I don't think we have this document yet. So do you think this is a major or an important starting point?
the idea of this meeting also to come and to share the experience from the other Arab countries. And apparently they are sharing the same struggle that we are sharing. I can, from today, the conclusion, we're all sharing struggles for the hemovigilance. But at the end, no, I don't think we have a strategy yet. Isn't it?
Yeah, but I wanted to ask you, Hind, who will be the mother or the father of this national strategy? Is it the Ministry of Health, or is it the regulator, or is it the Saudi FDA, or I mean, who in Saudi, for example?
Yes, we are at the end. The big father and mother is the Ministry of Health.
So,
but the Saudi FDA comes, and the patient, the Saudi patient safety is another partner. I think Saudi FDA and the patient safety, they're the big partners.
Okay.
And this is strategy for hemovigilance.
It's very important to identify.
Yes.
To start with.
Exactly.
So to know whom you are going to address.
Yes.
And how.
That's in our report. That's included in our report. Both Saudi FDA is an important partner, and the Saudi patient safety quality system is an important partner.
Okay.
Yeah. This is very important because one of the obstacles we have now to the reporting is what Dr. Mahas explained, is that the blame culture. So I think in a national framework or a regulatory policy, we should define that any or every staff who involved in hemovigilance is protected, legally protected, unless it is something, intentionally, that's something else. But if we define this, I think we will maybe remove 50% of the fear and things that would prevent. So this is why maybe in my opinion, I think this is an urgency to have a national hemovigilance policy or strategy. I'm very happy because it's already maybe 4 o'clock or something, and everybody's still willing to speak about hemovigilance. But anything to add or anything to maybe try to? Yes, Dr. Muna, you have anything? What you should promise us next? Let's say next year. What will be in your presentation different from now about hemovigilance?
I hope, Dr. Abdullah Mashi, we can finish our portal, at least our policy, hemovigilance policy, and define well the reporting line and the taxonomy. I think this is achievable, and inshallah, the potential portal for reporting, inshallah, it will be complete.
Inshallah. Okay.
And I think, Dr. Abdullah, there is no universal way of introducing hemovigilance to different countries. Each country has their own system, their own way, their own organizational structure, and even the size of the country is different from country to country. So I think each one should choose the best way of implementing their hemovigilance. I believe like in UK or Australia or France, they have their own approach to implement the hemovigilance. Still, we should put in mind always that they take 20 years or more than 20 years to implement the hemovigilance. So don't be disappointed if we are late a little bit, but it takes them maybe even 30 years to reach to this level of hemovigilance.
Dr. Salama, please. Yes, please.
مدكم بالتجربة التونسية excuse me pour اللغة الإنجليزية عربي التجربة بدأت معناها النصوص القانونية الكل 2007 بدأنا تجربة هيموفيجيلانس ووضعنا كل النصوص الترتيبية فيما يخص الكوميتي اوسبيتالي فيما يخص طريقة الإعلام من الكلينيكال سيرفيس للمركز نقل الدم ولا بنك الدم. كل هذا موضوع وواضح، وقمنا بعدة معناها التدريبات في الإطار هذا. الملحوظة إلى حد اليوم هي ألا معناها الشيء اللي تقال معناها طول المؤتمر هذا والوركشوب هذا ما عندناش معطيات وطنية فيما يخص ليموفيجيلانس. معناها عندنا بعض المعطيات معناها مربوطة بالستاف الفريق العامل في المستشفى، وبعض المستشفيات تعطي كل المعطيات بتاعها والبعض الآخر لا. أنا كنت في مؤتمر لمدة شهر بحضور كل السلطات معناها لوزارة الصحة، وحاولنا باش نتناقش في الموضوع هذا. من جملة ما تقال ومن جملة المخرجات بتاع الوركشوب هذا هي معناها فما جانب ثقافي، معناها الناس ماهيش معناها كما تقول بين الفريق تاع مركز نقل الدم، الفرق تعمل في مراكز نقل الدم والفرق الكلينيك كل واحد يقول المعطيات بتاعي، ومن جملة ما تقال احنا نمدكم بالمعطيات باش انتم تنشروها. بالتالي فما مسألة ألا معناها احتكار المعطيات، فما النوعية معناها الشيء من النوع هذايا. واحنا الكلمة المفتاح اللي أكدنا عليها اللي راهي ليموفيجيلانس ماهيش باش للمراقبة والمحاسبة، هي للمليوراسيون كنت معنا بالتحسين الدائم وباش نستغلها وباش نقدم في المجال هذا الكل. دونك هذا من جملة الأشياء. من جملة زاد المخرجات المؤتمر هذا احنا معناها فيه طريقة الإبلاغ والإعلان، معناها بعض الكلينيكال معناها سيرفيس معناها قالوا لنا طريقة الإعلان طريقة معناها صعبة وتتطلب برشا وقت، واحنا ما عندناش الوقت باش نعبي الفورمولا الموضوع وضعته وزارة الصحة للشيء هذا. بالتالي معناها من جملة ما تم اقتراحه هي معناها النيميريزاسيون، معناها عن بعد تصير وما تصيرش بطريقة كتابية، معناها
الإلكترونية يعني.
الإلكترونية بطريقة إلكترونية. دونك هذوما معناها نجم نقول احنا تو في البلدان العربية ما شفتش صراحة إلى حد اليوم بلد عربي عنده معطيات وطنية فيما يخص ليموفيجيلانس. احنا عندنا بعض المعطيات معناها إذا كان نقيمها فيما يخص معناها قاعد إذا كان ذاكرتي طيبة معناها 1.5 بالنسبة لكل 1000 معناها كومبوننت، معناها دونك تبقى ديما نسبة ضعيفة. معناها نقول معناها ما نهبطوش يدينا ومواصلة العمل ومواصلة الاتصال مواصلة الإقناع، والطريقة الوحيدة هي تبقى معناها حسب رأي معناها ما نبداش من فوق، نبدا معناها على كل المستويات كما معناها نبين لهم الارقام والاحصائيات اللي جات، ونبين لهم معناها بذاك هو راه ولا بنجم نحسن ونجم نقدم معناها في الميدان هذا.
شكرا جزيلا دكتور. تفضل دكتور. كم باقي عندنا؟
طيب شكرا دكتور سلامة، التجربة بتاعتكم ممتازة وكلام دكتورة عايشة برضه ممتاز في موضوع إنه فعلا we have to be a team, we have to work as a teamwork, not everyone alone and keep my data and don't want to give it. يعني work with all stakeholders including patients and donors, as I said before. All stakeholders, if they are involved, will be more strong. And what Aisha said about it, people who work for hemovigilance for 30 years to build it like shot, to build it in this way. We don't have to reinvent the wheel. We can learn from them and start simple. We don't have to start very complicated that people can fill the forms, can complete the forms. We need to start very simple and then we can improve, we can build up. But even in national system, we need to be in a simple way at the start. Give the people just the most important things, then start, build up on it and improve. This it will be excellent.
Sure.
Thank you.
That's right. Yeah. Yes. There is.
It's not perfect, but
yes.
Yeah, no way
yes.
back.
Okay.
Another mentioned also in the science of patient safety to linkage the incident reporting with the annual performance of the practitioner. Yani, for example, if you are a nurse and transfuse for example 100 patients per year, So you at least you have to report 1 year miss, for example, or one that's calculated somewhere. So they also examine the accuracy of the reporting because they wanted to validate if you are just reporting to complete your annual performance criteria or it's actually a near miss. This is also mentioned in some international practice.
In my opinion, this is, you will end up with either over-reporting. So to achieve my target, I will just report anything, whether it is reaction or not. And I need to, so I will just report it in the first month and I will never look at it again. So this is one tool, but it's need to be it's need to be validated, maybe, in my opinion. I think we should come to conclusion. I'll just hand the mic to Dr. Hind to conclude this session.
Thank you very much. We conclude the day. I would like to thank again all our international guests and our Arab country brothers and sisters, our local colleagues who came all the way. It was really excellent 2 days. Thank you, جمعية دمي. Really أصدقاء الدم وأصدقائنا. You did a great job. Thank you for my team, Hamad Al Yahya and Fatima and all the other teams and Ahad. They did a great job. They really helped me. We look forward for another successful workshop, inshallah. Thank you so much. I really appreciate it. It was great. I wish everybody safe flight back home. Thank you. Thank you.